Well, welcome to Grand Rounds, everyone. Very happy to see you all here today virtually. And I'm Dr. Betsy Trowbridge, and as most of you know, I am the Executive Vice Chair for the Department of Medicine, and I announce today. So just a few things. One, enjoy the winter solstice, which is next Monday on the 21st. And then I just do have two quick Department of Medicine updates that are very important. One, there has been an IS significant issue that occurred last night late, and many of you will not be able to sign in from your personal devices to Centrex. Your division administrators and your division chiefs have the instructions about how to do that, and you can contact them after this. Secondly, the next set of invites for vaccinations are going out today. So please watch your emails for those so that you can sign up for vaccines. And with that, we're going to start our grand round. So I would like to welcome very warmly Dr. Kelli Allen, who is a professor of medicine at the Division of Rheumatology, Allergy, and Immunology and the Thurston Arthritis Research Center. She is at the University of North Carolina, Chapel Hill, and she works as obviously in osteoarthritis. And to interview her today is Dr. Katie Miller, who is a CHS assistant professor who is doing research and has developed a multidisciplinary clinic in osteoarthritis care and has worked with Dr. Allen on some very exciting programs. So Dr. Miller?
Sure, thanks, Betsy. So I feel like I get to do my chief resident dream speaker all over again when I got to invite Dr. Allen to speak with us today. And it's really my privilege to introduce you to her. So she completed her undergraduate degree at Penn State University in exercise and sports science, followed by a master's degree from Wake Forest University in health and sports science, and then her PhD at Penn State University in biobehavioral health. So as Betsy mentioned, she is currently a professor at the University of North Carolina in the Division of Rheumatology, Allergy, and Immunology, and also the Associate Director in the Durham VA Healthcare System for the Center of Innovation to Accelerate Discovery and Practice Transformation. She has an extensive publication list of over 129 peer-reviewed publications. She's a journal reviewer for multiple journals and serves on many national and international committees, including the American College of Rheumatology Quality of Care Committee and the Osteoarthritis Research Society Joint Effort Committee, where I have had the privilege to work with her. She has numerous grants, including currently from the Department of Veterans Affairs, the National Institute of Arthritis and Musculoskeletal and Skin Diseases, the NIH, the Department of Defense, and the National Center of Complementary and Integrative Health. We are very lucky to have her joining us today as a guest of General Internal Medicine. So please welcome Dr. Kelli Allen, and I'm sure we will all learn a lot from her presentation today, Osteoarthritis Interventions and Care Models, Pursuing Meaningful Changes in Patient Outcomes. Thanks, Kelli, for being here.
All right, thank you. Good to be with you virtually. I guess I'm coming to you on an exciting morning in multiple ways with computer issues and vaccines and such. I hope you all enjoy what I have to say and look forward to some Q&A after. So the second slide, I'm actually not sure if I need to say anything about this. My disclosures are on here, but they're basically ones that are related to the types of funding that Dr. Miller mentioned from various organizations that are funds to my institution to do the research that I'll be talking about today. And as Dr. Miller said, I'll be talking about osteoarthritis interventions and care models, and particularly want to try to hone in on where we are and maybe where we can go in terms of pursuing meaningful changes in patient outcomes, because that's certainly what we are all wanting to do. I want to say just a little bit about the burden of osteoarthritis. Data from a population-based study showed that the lifetime risk of hip OA is 25%, and the lifetime risk of knee OA is 45%. So it's clearly a health condition that's affecting a large proportion of the population. And the figure at the bottom of the slide, and sorry, I'm just trying to figure out my two screens here. I think I've got it now. is this is a figure that's from the recent National Public Health Agenda for Osteoarthritis report. It's just been released over the past few months, I think. And it really shows some other, I think, pretty striking impacts of osteoarthritis. For example, over half of adults with OA are of working age, so there's a lot of people that are out there, as I'm sure you know well, trying to manage their work situations in the face of pain and functional losses. There are clear costs, including about 71 billion in annual earning losses and 65.5 million in annual medical costs. And this figure, again, just talking about the impact of osteoarthritis, it shows data from the National Health Interview Survey, including both the actual and then the projected prevalence of doctor-diagnosed osteoarthritis, the majority of which is OA, of course, through the year 2040. And as you can see, the prevalence is projected to rise substantially to about 78 million in 2040, compared to what's about 63 million now. So these data really also illustrate that OA is going to have an increasing burden on not only individuals, but healthcare systems. And I think that really highlights the importance of developing and also implementing effective and efficient care models. I wanted to touch briefly on the particular burden of osteoarthritis among U.S. military veterans. Since, as Dr. Miller mentioned, I've worked partly in the VA, and several of the studies I'm going to talk about today were conducted in the VA healthcare system. So 1 in 3 military veterans have arthritis, compared with 1 in 4 adults in the US overall. And again, that's arthritis more globally, but the majority of that is osteoarthritis. US military personnel, many of whom are relatively young, have twice the risk of knee OA than compared with the general population. And that's largely due to injuries and loading that occur commonly as part of military service. Not the only reason, but that's certainly an important factor. VA healthcare users have a particularly high burden of OA, even higher than the veteran population overall. And then 40% of VA healthcare users have knee arthritis, and of these, about 60% say that they have activity limitations that are directly due to their arthritis. So just overall, this is a particularly vulnerable population group with respect to osteoarthritis. And since the focus of this presentation is OA interventions and care models, I wanted to give a brief overview of treatment guidelines to set the stage. I'm sure you're all very familiar with either these guidelines or maybe some other guidelines since you are treating patients with osteoarthritis, but I just wanted to give a little bit of an overview before we move forward. Again, there are many guidelines out there, but these are the 2019 American College of Rheumatology treatment guidelines. And the darker green treatments here are the ones that are strongly recommended, lighter are conditionally recommended. So just note that the strongly recommended treatments include both pharmacological and non-pharmacological approaches. And specifically looking at the bottom, the ones that they rated as strongly recommended are oral NSAIDs, topical NSAIDs, and then intra-articular steroids. Particularly for hip and knee, these guidelines include hand as well. Other treatments on there, both for non-pharmacological and pharmacological, are ones that are they're conditionally recommended, often just because the evidence base is not quite as strong yet, but they're ones that are commonly used in practice as well. And then looking at the non-pharmacological approaches, the ones that are strongly recommended include exercise, self-management programs, weight loss, Tai Chi, and then some more specific treatments that usually occur in the context of rehabilitation visits, like using canes and knee braces and orthoses for hand OA. And just one other thing to point out is that these guidelines and other guidelines internationally really do emphasize that those rehabilitation and weight management and lifestyle types of interventions are ones that should be started first and should be continued throughout the course of treatment, though admittedly they are more difficult to achieve, some of them. And on that note, a number of studies have really illustrated that there are challenges with respect to osteoarthritis management, particularly behavioral and rehabilitation types of things. And here's some of those data. 70% of individuals with OA don't meet physical activity recommendations. About half report that a healthcare provider recommended physical activity specifically related to their arthritis management. 41% of overweight patients with arthritis say that their healthcare provider recommended weight loss as a strategy for helping with their arthritis. But about 80% of people with OA are overweight or obese. And then only about 11% say that they have ever taken any kind of formal class to learn how to manage their arthritis. And I think really most of these statistics, particularly the ones about weight management and physical activity recommendations, are just an illustration of how difficult it is to find time in routine clinic visits to deal with the complex issues of the more behavioral aspects of arthritis management. And these are data from the National Ambulatory Care Survey showing the use of physical therapy, and that's in blue, lifestyle interventions, which are in orange, and opioid use, that's the darker dashed line, NSAID use in the lighter dashed line. These go from 2007 to 2015. And these are all visits these are data from the context visits in which OA was treated, either in orthopedics, which is on the top, and primary care on the bottom. And in both graphs, we see that both NSAIDs and narcotics or opioids have increased over time. During that time period, I would strongly expect that the opioid line will have dropped between 2015 and now. But importantly, if we look at the PT and lifestyle lines, they are either flat or decreasing over time, and they're relatively low. So they range from about 50 or less than 50 to 200, 250. The rate that is the rate per 1,000 visits. So I think these data also suggest that we need to foster more use of behavioral and rehabilitation therapies for people with knee osteoarthritis. So I'm going to talk next about two studies our team conducted in an effort to enhance overall management of knee and hip OA in primary care settings. These two studies both had the same title. One was VA and one was conducted at Duke. They were both called Patient and Provider Interventions for Managing Osteoarthritis in Primary Care. We used the same two interventions in both studies. There was a patient intervention that included 18 calls over 12 months, and those focused on physical activity, weight management, and cognitive behavioral pain management, or CBT. And the provider intervention involved delivery of patient-specific recommendations delivered to the primary care provider through the EHR, and that occurred shortly before each patient's first visit to that provider in their intervention period. And the recommendations we used were based on OA treatment guidelines at that time, as well as algorithms that our team, which included a lot of clinicians, developed to designate which treatments may be appropriate for a given patient based on their symptoms and the treatments they were already taking or had already tried. And you can see here the treatment recommendations that a patient could have received or a provider could have received for a patient include referral to physical therapy, referral for a knee brace specifically, and that's particularly relevant in the VA because it's a little bit of a different referral stream, referral for a weight management program, referral to physical activity program, referring or just doing a joint injection, prescribing or recommending topical NSAID or capsaicin, some safety things related to NSAID use, discussing the possibility of trying just a different pain medication than they were currently using, and then in pretty limited cases, referral to orthopedics for evaluation for joint replacement surgery. So this is the design of the VA study, the PRIMO VA study. We randomized 30 primary care providers at one site in Durham, North Carolina, and 300 of their patients to receive a combined patient and provider intervention. Okay, so this was a two-arm study. They either got the combined intervention or it was usual care. And then the design of the Duke study was a little bit more complicated. We first randomized 10 clinics. Those were both internal medicine and family medicine. And they received, at that level, the providers in those clinics either received or did not receive the provider intervention. And then within each clinic, we further randomized patients to receive or not receive the patient intervention. So you can see on the bottom of that lower box, what that meant was that we could compare 4 groups. That was people who got the patient and provider intervention, provider only, patient only, and the usual care. So in this figure, I'm showing the primary results from the PRIMO VA study. Our primary outcome was something called the WOMAC score, and you'll hear me talk about that across most of the studies that I described this morning. It is a self-reported, well-validated measure of pain, stiffness, and function. And the WOMAC, lower scores are are better. So as you see them decreasing over time, that would indicate improvement. And for the Primo VA study, we found that at the primary outcome point, which is at 12 months, you can see in the box, there was a significant improvement in the WOMAC score for the combined Primo intervention group, which is the darker line on the bottom, compared with the control group, which is the lighter line. So the summary here is that the Primo intervention, combined intervention, was effective in the VA trial. Now, findings for the Duke study were a little bit different. Again, the primary outcome was that same WOMAC measure, and the primary outcome time point was again at 12 months. And at that 12-month follow-up, there were no differences, statistical differences in the WOMAC score across the study arms. You can see that in the red box. You can see the confidence intervals overlapping. But in this case, everybody improved. And you can also see in this red box, there was some heterogeneity in the baseline WOMAC scores for the across the treatment arms. I won't go into detail about why that is. I'm glad to talk about it at the end if you would like. Basically, it's a kind of a risk of cluster randomized trials like this one that we don't have when we do randomization at the patient level. But here, what we ended up happening was that usual care group. You can see there the dark line on the bottom. They started out at a pretty clinically relevant difference, being better, less symptoms, particularly compared to that highest group. So they were the best off at baseline and continued to get better as the study period went on. So I think it's interesting to think about why the intervention we studied seemed to be effective in the VA study and not quite as much in the Duke study. And I think one likely reason is that the starting point of our participants in terms of their baseline symptoms. So this table, you can see the red box, I'm showing the baseline WOMAC scores for all the treatment arms in both of the studies. And what you see here is that, again, the VA patients were a good bit higher, and that's a difference in WOMAC that I would say is quite clinically relevant. And then you can see in this right-hand column that in the VA study, only the intervention group really improved. But then in the Duke study, as I showed in the slide earlier, everybody improved. And I think the message here is that these types of adjunctive interventions might be most helpful for patients with a higher disease burden at the outset, whereas patients who have more mild to moderate symptoms are likely doing relatively well with the usual care they're receiving. And again, all of these patients in these studies were under care by a primary care clinician for OA, either in the VA or at Duke. So this idea that it may be more important for patients with more severe symptoms really needs to be explored more, but I think there's some general logic to the idea that targeting interventions like this to patients who do have worse symptoms makes sense, and those are the people who may need more help with disease management. And I wanted to say a little bit about, or show a little bit of data on the treatment referral patterns in the VA study. We had good, robust data on that from the electronic health record, though we didn't quite so much at Duke at that time. So this figure is showing the usual care group in dark blue and the intervention group in light blue. And for each, we first show the proportion of patients who were referred to a treatment, and then the proportion who actually received that treatment. And that was all during the study, their individual study period. And first, let's look at the joint injections and orthopedic visits on the right. And the bottom line here is that we really didn't see much change compared with the intervention and the control group. But then shifting over to these more behavioral and lifestyle treatments, so physical therapy, knee brace, and MOVE, which is the VA's weight management program, we do see some interesting differences. And in general, what we saw was that providers in the intervention group did tend to refer more. And you see that for each treatment, you see that again, it's on the left-hand side. But we didn't see any substantial difference between the two groups in terms of what patients actually did. So for example, let's look at the MOVE program at the right-hand side of the red box. And we see that about 30% of intervention patients and 5% of control patients had a referral for MOVE in their study period from their PCP. So I think that's a pretty substantial difference, particularly since these patients were likely only seeing their primary care provider 1 or 2 times during their study period. But then if we look at treatment received, not that big of a difference. 8% of intervention patients and 2% of patients, control patients, actually initiated MOVE. So there's some difference there, but again, not nearly as large as the referral patterns. And I think the message here is that it was pretty easy for providers to increase their referrals to these types of services, and that's particularly in an integrated health system like the VA. But it's harder to engage patients in the use of those therapies. I think we really need more intensive interventions that engage patients in the shared decision-making process regarding their OA management and the potential advantages of those types of treatments. But again, that takes time and is often difficult to do it in the context of short clinic visits. And then also thinking back to the overall findings I showed for the VA study, we did find that the patient and provider combined intervention was effective compared to usual care. And since we really didn't see any substantial differences in patients' use of these clinical services, I think we can likely conclude that the improvement we observed in that group was driven largely by the telephone-based patient intervention. So I'm going to shift a little bit now and talk about work going on really internationally with respect to osteoarthritis care models and innovations. A few years ago, I worked with an international group. This group is still coalesced in a different form, and that's the group, the Joint Effort Initiative that Dr. Miller mentioned earlier. So this is a paper we did in 2016 that summarized the work to date on osteoarthritis care models, and these are the example programs here. Many of these programs are still ongoing in different countries and being evaluated, so I think literature will continue to pop up about their effectiveness. But even since then, there have been some newer studies of OA care models, and I'm going to talk about a couple of these. Really, the first robust study, I would say, of an integrated OA care model is called the Mosaic trial, and it was conducted in the UK. And their model involved one initial consultation with their GP, followed by referral to a nurse-led OA visit, and then use of an OA guidebook by patients on their own. So these researchers examined the impact of Mosaic on many quality indicators, as well as some patient outcomes, but only a few metrics changed. And I'm showing here in the red box that, in their language, paracetamol increased when appropriate. But for all of the other quality indicators shown on this slide, including a number of metrics of both disease assessment and core management, there really were not any substantial changes compared with usual care. A couple of other metrics they saw that improved were giving of written information, general education information, and exercise advice to patients. And this slide is showing data from their primary patient outcome, and what you can see here was there are no differences between the intervention and control groups with respect to that outcome, which was the SF-12 overall physical health score. And one challenge this group observed with their model is that utilization of the nurse OA clinic or nurse visit, which was really the core of their intervention, where the meat of things happened, use of that service was lower than they expected. What they really wanted to see is that was every patient referred use that service, but it definitely was not the case. And they really expect that's why they had relatively limited effectiveness. So this study, I think, again shows that simply increasing referrals, in this case to a nurse-delivered OA clinic, might not be enough to elicit patient engagement and therefore changes in outcomes. This is another recent OA care model, this one done in Norway. It also started off with a GP consultation, and then they moved on to a series of activities that were led by a physical therapist, and also include an optional weight loss program. And then there was discharge back to the general practitioner. And in this study, they did observe substantial or significant improvement in their primary outcome, which was patient-reported quality of care. And they also saw increased referrals to physical therapy, increased activity, and decreased referrals to orthopedics, particularly for surgery. So in this model, I think they did observe some successes, but it was a little bit more narrow in terms of its focus on activity and physical therapy. Not a bad thing, just a little bit of a different kind of model. Here are just a couple other examples of ongoing large clinical trials that are testing comprehensive OA care models in other health systems. The partner study shown on top is currently being rolled out in Australia. And again, starts with a GP consultation, and that's followed by a relatively intensive intervention that's delivered by what they call a multidisciplinary OA care support team. And then on the bottom, CONACT is a study that's ongoing in Singapore. It involves exercise and clinical assessments for all patients, and then they have weight management and psychological interventions, which are just for patients who meet certain criteria. Results aren't available from either of these studies yet, but I think one pattern that at least I see emerging is that the interventions and care models that are being tested now seem to be getting more comprehensive and have stronger behavioral and rehabilitation components. And I think that's likely in response to the limited effectiveness of prior models that were less intensive and had more limited support, particularly for weight management. So in addition to these large trials of OA care models, we're seeing a growing number of clinics and healthcare systems developing and implementing what I would term sort of homegrown models. Some of them are based on the models that have been studied previously. And I'm going to talk about two of those. This first slide shows a figure of Duke University's Joint Health Program. And in general, this model involves referral from a physician. It started with their orthopedic department, but now they are taking referrals from anywhere in the healthcare system. And that referral is to what they call a primary OA provider, which is a physical therapist in this case. And that person, and that physical therapist does provide direct treatment. So they get exercise prescription, functional training, education, the things that you would normally get in routine physical therapy for knee OA. But they also then become kind of an osteoarthritis care navigator. And you see that in this other red box. So what they will do is they will refer patients to other services like cognitive behavioral therapy, sleep services, and nutrition or weight management. And they haven't officially published data on this model yet, but they've had this up and running for 2 or 3 years and have been really pleased with the patient outcomes they're collecting, as well as the number of referrals they receive. So I would say this is a successful model. Some limitations just anecdotally is that for patients with limited access in terms of health insurance to physical therapy services, these wouldn't meet the needs of those types of patients. But for patients who are able to, who have that kind of insurance and are able to afford the typical physical therapy co-payments, this model seems to be working pretty well. And then the other model I certainly wanted to discuss today was developed by Dr. Miller at your own institution. So some of you might be quite familiar with that model, but if not, now is your opportunity to learn more about it. So briefly, this model includes 1 to 5 visits over a year. That it really deals with comprehensive OA management. And you can see in the blue box kind of in the middle, the components of that. So there's assessment of pain, function, mood, and other medical conditions, goal setting, exercise prescription recommendations, weight loss intervention, medication and joint injections for pain management when that's appropriate, addressing of mood disorders and chronic disease management in coordination with the PCP, addressing bone health when that's appropriate, and then for some patients, optimizing medical conditions in anticipation of total joint replacement. And then you can see in yellow and green boxes, there are also optional shared medical visits and expedited referrals to other specialties. And some data from this program, among the first 50 participants in the program, they found significant changes in BMI and function, which are 2 really high priority outcomes for sure for people with knee osteoarthritis. And then 88% of patients have said that they would likely or definitely refer to a friend, and that's a pretty standard patient satisfaction measure, and 88% is certainly a really good indicator that patients do get what they're hoping to out of the program. So I think it's interesting, these homegrown types of models maybe seem to be perhaps even a little bit more successful than some of the OA care models that have been studied in large trials. It's difficult to make those kinds of comparisons because in the trials, these interventions are compared with, something like a usual care model. And in these more homegrown types of situations, the evaluation is usually just a pre-post among patients. But I think there are some advantages to these internally developed types of programs since they're built to fit within the local context and surrounding the resources that are available locally. So I'm going to shift gears just a little bit here and hone in on some evidence for more rehabilitation and exercise focused interventions and care models for OA. And I'm showing in this slide that there's really a gap in supply of physical therapists that may not be super evident to you or me in the maybe less rural areas that we are in, but it's certainly a challenge for people in rural areas. And this combined with the rising prevalence of osteoarthritis really, I think, illustrates the need for figuring out some efficient models for delivering rehabilitation services for the OA. And I'm showing on this slide some data from the Johnson County Osteoarthritis Project, which is ongoing in North Carolina. And I think they really nicely illustrate the importance of rehabilitation and exercise interventions, particularly for knee osteoarthritis. So these data are showing the association of baseline symptomatic OA, and I put that in red, with incident cardiovascular disease over a period of about 6 to 7 years. So at baseline in these analyses, none of these patients had cardiovascular disease. In the column that's labeled unadjusted results, we can see that people with symptomatic knee OA at baseline had 1.5 times the odds of developing cardiovascular disease compared to those without symptomatic knee OA. And then in what I've labeled model 1, we're controlling for physical function. In particular, in these analyses, we're controlling for chair stand tests. It's a relatively standard measure of physical performance. We did these same analyses with other function tests and found similar results. That we're controlling both for baseline function and then change in function over time. And what we see in model 1 is that the association of symptomatic knee OA with incident cardiovascular disease is reduced and becomes no longer statistically significant. And so what this is showing that at least part of the association of knee OA with future CVD risk is through a pathway of functional loss. And so that highlights the importance of helping patients with knee OA to improve or maintain function over time. So I'm going to talk now about a study our group conducted of a group physical therapy model, and this was conducted in the VA. We randomized 320 veterans with symptomatic knee OA to receive either individual PT, so a standard model, or group PT. And the individual model we used was just what was going on at our local VA at the time, and that was 2 one-hour visits with a physical therapist, 2 to 3 weeks apart, but then they could be referred out for additional services if that was appropriate. In the group PT model, we had 6 one-hour visits over 12 weeks, and we had usually about 8 patients per group. In our case, it was co-led by a physical therapist and a PT assistant, and it primarily focused on group exercise. There was an educational component as well. But then each participant also had a couple of individual consultations with the physical therapist. Similar to how that's often done in the context of other shared medical visits, we just pulled people out from the exercise class at a couple of different points and did what would be normally done normally as a part of an individual PT evaluation and kind of fine-tuning their exercise prescription. So these are the main results from that trial. We found the participants in both the group and individual physical therapy arms improved meaningfully in their WOMAC scores over time, in particular at the 12-week point, which was right after the intervention was finished. So importantly, effects were as good, or actually for some of the other outcomes better for individuals in the group program compared to relative to the individual program. And so really what that's saying is that a group model can be a viable option, and that can increase efficiency and reach more patients compared to traditional individual therapy. So following completion of that trial, the physical therapy service at the Durham VA continued to offer this as a clinical service. And we evaluated outcomes in a small group of participants for them. And basically what we found was that people in this now ongoing clinical group PT program they are seeing improved outcomes, the same as what we saw in the trial. And so you can see some of those data here. Chair rises, performance increases over time, pain intensity is decreasing, and also seeing decreases in that WOMAC total score. So now we actually have funding to do a 16-site implementation trial of this same group PT program in the VA, which will be starting in 2021. This is another study that our group did relatively recently. It was comparing physical therapy with an internet-based exercise training program, which I'll abbreviate IBET from here on. And this was called the PAP-IN study. So you can see we randomized 350 patients. Standard PT was between 3 and 8 visits for people in that arm. And the components of that were just based on usual PT practice for NEOA. The internet-based training program, which I'll show more on in the next slide, or people could be assigned to a waitlist control group. Outcomes were assessed after 4 months, which is right after the completion of the window for the PT visits, as well as at 12 months. So the internet-based exercise training program we used involved tailored exercises, and it was based on patients' pain, function, and current activity when they started the program. It also involved exercise progression recommendations, and those were based on repeated measures of pain and function. There were photographs as well as videos showing patients they were assigned exercises. There were automated emails reminding people to log in and use the program, and then some progress tracking functions. So here are some data on participants' engagement with the intervention. In the IBET group, the majority, about 80%, logged onto the website. However, frequency of the use of the website was quite low. At 4 months, the median number of days on which patients logged on was 10, and that increased only to 11 over the full 12-month period. But what we don't know is how often participants may have been doing their recommended exercises, even they weren't on the website. It was not a requirement. Once they learned what exercises were assigned to them, that they continue to log on. So they may have learned those, printed them out, and been doing them on their own. We just don't have good data on that. And in the PT group, we really had good engagement. 94% of participants in that arm attended at least one visit. About half attended between 6 and 8, and 8 was the maximum, and the median was 4 visits. This data shows the main results from the PAP-IN trial. We found that there were decreases or improvements in WOMAC scores that were similar for the PT group, which is in red, and the IBET group, which is in blue. So that was some indication that for study participants overall, IBET seemed to be as effective as PT, potentially indicated that that type of internet-supported home-based program could be used by some patients, particularly for those who have limited access to PT, or don't want to attend because of co-payments or time or distance or those sorts of things. One important caveat is that in this trial, the waitlist control group, you can see in yellow, also improved. And overall, you can see that the difference between the groups was actually on the border of statistical significance. You can see by the somewhat overlapping confidence intervals. So we also found that for participants in the PT arm, outcomes were substantially different, substantially better for people who attended more visits. So you can see in this figure on the far right, people who attended 6 to 8 of that total possible 8 PT visits had the largest decreases or improvements in WOMAC scores, and that was both at 4 and 12 months. So I think this is yet another illustration of the importance of understanding how we can best engage patients in different types of clinical services for OA. Okay, I'm going to move on to another study here. This is recently completed and I think will be published in the next day or so. So this program is called, the project is called STEP KOA, or Stepped Exercise Program for Veterans with Knee Osteoarthritis. And this study, well, let me first say about the the rationale for a step care model, which you see in all kinds of health conditions, different health conditions, including pain management, is that we're trying to reserve the more limited or costly or resource intensive services for patients who don't make improvement with some less intensive types of treatment. And particularly in the VA context, physical therapy services are somewhat of a limited resource. Things have shifted a little bit in terms of, now people being more eligible for community care, but it remains that actual physical therapy resources in our health system are quite limited. And again, that can be true for some other settings, including rural areas as well. But in this model, you can see starting on the left, patients started out with access to that same program, that internet-based program I described for the prior study. And then after 3 months, we assessed everybody to see if they made clinically relevant improvement in pain and function using some established criteria. At that point, if they had not made improvement, patients stepped up to the next step, which was biweekly telephone-based activity coaching calls for 3 months. And then after another 3 months, we assessed patients for those clinically relevance criteria again. And at that point, people who were in step 2, who hadn't made clinically relevant improvement, moved on to step 3, which was physical therapy visits. And then also at that same time point, if patients were still in step 1, but they had regressed and they were no longer at that clinically relevant threshold compared to baseline, they then moved up to step 2, which they would not have had yet. So first I'm showing some data of an overview of the proportion of patients who stepped up to step 2, which is in the darker blue, and then step 3, which is in pink. The green are people who we couldn't determine their status because of some missing data. And the light blue are people who stayed at step 1. So about 20% throughout the study period remained at step 1, indicating that for some patients, this type of internet-supported home-based program is likely effective and maybe all they need, at least for the time being. And then 65% advanced to step 2 at either 3 or 6 months, and about a third, 35%, advanced to those PT visits. So this figure shows the primary results from the STEP KOA trial. Again, this WOMAC is our primary outcome, and you can see that at the primary outcome time point on the far right, which is 9 months, the STEP KOA program resulted in significant improvements in WOMAC scores compared with usual care. So these results suggest that STEP KOA could be just another type of approach to enhance the efficiency of delivering those exercise and rehabilitation therapies for NEOA. And so to follow up on this study, we now have funding from the VA's Office of Rural Health to begin implementing a fully telehealth supported version, including those physical therapy visits of this, particularly among rural veterans with NEOA. So one important challenge to the overall impacts of OA interventions and care models is the heterogeneity we see in impacts across patients. So here I'm showing their spaghetti plots. So each line is for an individual patient, and these are representing changes in WOMAC over time for people in the different intervention groups in our STEP KOA study and in the PATH-IN study, including both the internet-based treatment and the PT treatment. You can see they're just all over the place. There's tremendous variability. For all of these interventions, we saw an overall mean improvement, but what an individual patient can expect is really just hard to know because of this tremendous amount of variability that we see. And so I really think that if we can start to understand this heterogeneity better, it'll help us to be able to figure out how we can best target different interventions for different patients. So kind of the idea of more of a precision medicine approach. So our group has started doing some work using different machine learning approaches to try to start getting a handle on this heterogeneity. So I'm going to show you a couple of exploratory analyses of this type, both from the PATH-IN trial. So this first set of analyses, it's using something called qualitative interaction trees, or QUINT. And in this set of analyses, we're simply comparing the 2 active treatments for PATH-IN, so IBET, the internet-based program, and PT, and the PT arm. So one good thing about these types of analyses, these machine learning analyses, is they can use all available patient characteristics that we have to identify subgroups, often of which they are defined by more than one patient characteristics, and I'll show you what I mean in a moment. In these particular analyses, we identified 4 subgroups. The ones in red are those for whom IBET was best, and the ones in green are the ones for whom PT was best. And so looking first on the far left, there's a subgroup for whom who had low BMI. And for these patients, IBET was actually better. And then in contrast, looking on the right, people who had higher BMI and then had arthritis for longer based on self-report, PT was the better treatment for them. For people in the middle, there were some differences, and the results weren't quite as clear. And there were some differences based on their self-reported social support. But I think some pretty clear messages from here, showing in this box, is that patients with low BMI did well with PT, patients with high BMI and longer duration of OA symptoms, the latter did well with IBT. These patients with higher BMI are doing better with PT. So these are certainly exploratory, and we need to do more work here, but I think these may be starting to give us some understanding of who we might want to most strongly consider for PT referrals. So these are some similar analyses, but using a different algorithm. This one's called tree-based interpretable learning. And in these analyses, we're including all three groups from the PATHN trial, so IBET, PT, and waitlist. And in this first red box, you can see there is a group with the lowest BMI. Just in the cutoff for BMI is just selected by the algorithm. Those patients, again, consistent with the prior slide, the internet-based program was actually the optimal treatment for them. This red box is showing people who had kind of a medium level BMI, but also had fear of movement. So that's what BF is the abbreviation for here. So medium BMI, but they had some fear of movement, or what we call kinesiophobia. PT was better for them. And then here, there was actually a group for which waitlist was what was the actual optimal treatment. And really what that's showing is that these patients with the highest BMI just didn't benefit from either PT or internet-based exercise training. And interestingly, these results are completely consistent with some other analyses our group at UNC has done on a completely separate trial, which also found that patients with in their highest BMI group they really did best in a weight management group versus exercise plus weight management. So I really think it's encouraging to me that we're starting to see some of these same patterns emerge using different studies and different algorithms. Again, these types of analyses, we can put 40, 50 different patient characteristics in it. And I think it's, again, encouraging that we're starting to see some of these different, or some of the same treatments emerge as being important. So I'm going to begin to wrap up here, just as some overall conclusions. One is just that OA care models are rapidly proliferating, and we see that both in research and in clinical practice. And I think that's due to the growing recognition that we probably need to be doing something more systematic to make sure patients are getting access to comprehensive treatment, particularly around those behavioral and rehabilitative programs that they're often just really too much to handle in the context of at least a primary care visit. Light touch interventions seem to have limited effectiveness, although they're appealing from a feasibility standpoint. But then interventions that include stronger behavioral components seem to have a good impact. There's some gaps to note. We certainly still need evidence-based models that can be feasibly integrated into health systems, importantly, including how those are going to be paid for. We need, I think, to capitalize more on community partnerships where maybe we're reaching out to those YMCAs and other types of organizations to deliver more systematically those behavioral components. And then, as I just mentioned, I think we need to do a lot more in precision medicine to figure out who do we need to target for Dr. Miller's OA program, who do we need to send to PT, and those sorts of questions. And I just wanted to show, lastly, some resources. There are a bunch of resources out there for patients and healthcare providers dealing with OA management. I just wanted to mention these. I'll just leave them up here because I think we want to wrap up and leave some time for Q&A.
Dr. Very much. That was fantastic. Let me just get my screensaver on. I think the proliferation of these, non-operative programs has been fantastic. And, at the beginning of your discussion, you said, all of us are familiar with the guidelines. And, from the research you showed, while we might be familiar with the guidelines, we do not follow the guidelines well for osteoarthritis. And so I think that your work is fantastic. So A question here, and then I may have some questions later as well. So one question that came in is, what do you believe is the cause of the increased burden of osteoarthritis? Do you believe it is related to our increased obesity rates?
Yeah, that's what the data seem to suggest. Well, it's really two things. One is an aging population. So that's a driver, and increased overweight is the other driver.
Great. And then from my perspective, I think your gaps were really critical. And I think in value-based care systems, the gap to be able to pay for these programs is the biggest issue I worry about. Although, frankly, I think that the research you're doing with the STEP programs shows that this could be very cost effective. Are you doing some work in your research work with looking at the cost comparison to your STEP programs to other programs?
Yeah, I mean, so for me personally, not necessarily comparison, that's harder to do. I mean, you can do that anecdotally, but in the STEP KOA trial, we actually have an ongoing formal cost effectiveness analysis going on. So I think, for OA programs like this, we typically don't see huge changes in the short term in terms of patients' medical costs. So unless you can follow patients probably 5 years or more, it will be hard to see reductions in total joint replacements. That's the big cost driver. We'd like to do more like that, and we may be able to do that for especially for our VA patients where people remain in the system pretty consistently. We can do that. We can start to follow more. We typically don't see when we do these management programs that people drop substantially in their medication costs because they're just not that expensive. But what we can show and are starting to pay more attention to is showing, for this amount of cost, because these programs just frankly are not super expensive, here are the changes in, in patient metrics.
Yeah, quality of life.
Yeah, so we typically do see, when we do these formal cost effectiveness analyses, we do see really good data in terms of cost per unit of quality of life increase and those sorts of things.
Thank you. Other questions today for Dr. Allen? I'm just going to wait, Dr. Allen, just a little bit for other questions to come in. And check the chat here too, just a second.
Yeah, I'm monitoring the chat. I'm not seeing anything at this point.
And a question from Dr. Christy Bartles. She is our division chief for rheumatology. Thanks for an outstanding presentation. What is your evidence-based advice for weight management?
That's a good question. There are a number of effective programs out there. I mean, Weight Watchers has an evidence base, and I don't know what your institution has. I think, we're getting into just personal opinion here, but I think something that a patient is going to do is really the best. Is probably what's most important, because there's a bunch of things that, I mean, you can look in the literature and see which ones have been tested, but I think the biggest thing with weight loss is helping patients to engage and sustain. And because of that, I think the key really is to try and understand what they're going to be able to, what do they gravitate to? What kind of program are they going to actually at least try? So within the broader umbrella of, yes, there is some evidence out there that this particular program works. It's really trying to find out what works logistically for a patient. Behavioral weight loss. I mean, there's evidence for low carb diets, and that those are harder to sustain over the long term. And I think really the best evidence is for those just general, behavioral weight loss programs.
Mm-hmm. Thank you.
Mm-hmm.
I see another something coming in that's being typed, I think, at this moment. So how do occupation, previous exercise, like running, influence the development of osteoarthritis down the road?
So there is good evidence for occupation. Repeated things like knee bending, kneeling, squatting is a risk factor. That risk factor is substantially exacerbated for people who are overweight. So that's the best counsel if you have somebody who is in an occupation where they are having those risk factors, even if they're not symptomatic yet. And, you know, admittedly, again, weight loss is difficult, but that is pretty well established that for people in those jobs, adding overweight and obesity is going to compound that substantially. In terms of things like running, there's no strong evidence that it increases risk for knee or hip OA overall. However, there's abundant data on ACL injuries and post-traumatic osteoarthritis. And there are probably also some people, depending on biomechanics, for whom running maybe not the best. And so if you have somebody who's an overpronator or just doesn't have good running mechanics, they may be predisposing. But for the population in general, running is not a strong risk factor. You start to see some equivocal data about that when you get to people who were like ultra marathoners. But for most of us who are trying to run a little bit, it's not a risk factor.
Thank you. And I'm just taking a look here. I think that is the end of our questions. So I just want to thank you, Dr. Allen. I think that this thoughtful work is making us, change our paradigms in how we deal with these chronic disease issues that are so burdensome for our society. So thank you very much. Dr. Miller, any other last thoughts?
No, I just want to thank Dr. Allen for being here and for being a mentor and letting me in as well. So thanks.
Yeah, thank you very, very much for that. Really appreciate it. And so everyone stay safe, and thank you for enjoying our grand rounds today.
Thank you.
Yeah, so this was fantastic, Kelli. Really.